Bismillahirrahmanirrahim. This video is about actinic keratoses and these are the references for this video. The actinic keratoses is studied under the head of pre-malignant and malignant epidermal tumor. The term actin means ray. So this keratosis that is due to rays of the sun is actinic keratoses. The other names for these are solar keratoses and senile keratoses. There is a sun damaged skin that is repeatedly damaged, and there is development of hyperkeratosis. The predisposing factors are lightly pigmented individuals, ionizing radiations, industrial hydrocarbons and arsenals. The series of events that occur after the chronic stimulation or chronic irritation, they follow the same pattern as occurs anywhere else in the body. For the epithelial malignancies, there is dysplasia, hyperkeratosis, parakeratosis, dyskeratosis, and development of carcinoma in situ that can lead to development of squamous cell carcinoma of the skin. There are a number of conditions that are associated with skin reaction to sunlight. This is a simplified classification for these conditions. These include phototoxicity, photoallergy, idiopathic conditions, metabolic and nutritional disorders, DNA deficient photodermatosis, photoexacerbated dermatosis, and chronic photo damage. Phototoxicity include sunburn, drug or chemical induced injuries, plant induced or photodermatitis. Then photoallergy includes drug or chemical induced injury, chronic actinic dermatitis and solar urticaria. Idiopathic conditions include polymorphous light eruption, actinic prurigo and hydrova vacciniforme. Metabolic and nutritional conditions include porphyria cutanea tarda, variegate porphyria, erythropoietic protoporphyria and pellagra. DNA deficient photodermatosis include xeroderma pigmentosum and other rare disorders. Photoexacerbated syndrome, dermatosis, and then finally the chronic photo damage that include dermatolithiosis, dermatohiliosis or photoaging, solar lentigo, actinic keratosis, and skin cancer. So we are here dealing with actinic keratosis. Actinic keratosis is a disease of middle age, but younger people are also affected if they are fair skinned. It is a disease that is predominantly present in male, and skin phenotype 1, 2 and 3 are commonly affected, while rare in skin phenotype 4, and almost it never occurs in people with black skin. It is more common in people having occupation that involve outdoor work, such as farmers, ranchers and sailors, and also people who have got outdoor hobbies such as tennis, golf, mountain climbing and deep sea fishing. The lesion of the actinic keratosis is usually less than 1 centimeter in diameter, and the color is variegated, but it is usually tan brown to red or skin color. The consistency is rough and its surface is like sandpaper. Grossly, it may form cutaneous horn due to excessive keratosis, and usually affected sites are face, arm and dorsum of the hand, the areas that are exposed to sun. And the actinic keratosis affecting lip is termed as actinic cheilitis. The border of these lesions are irregular. So this picture is showing the features of actinic keratosis. The lesions are tan brown, red or skin colored. These are circumscribed and having a rough surface. There is another picture, and this picture is showing that there are numerous red or skin colored circumscribed lesions that are rough in appearance. So this is the gross picture showing actinic keratosis lesion. These are erythematous and brownish macules and papules, and there is coarse adherent scale that is confluent on this sun exposed skin. The hyperkeratotic areas are yellowish in color, in fact yellowish gray, and they are better felt. They are rough in consistency, and the helpful diagnostic finding is that when you gently abrade the lesion with a fingernail, this induces pain. This is another picture that is showing these abrading lesions. This hyperkeratosis area is painful, and when it is removed it leaves an erosion. This area has got a different morphology. There is presence of this rolled out margin, and this is a basal cell carcinoma that is present in this area along with the actinic keratosis. This is the gross picture of actinic keratosis at higher magnification. There is a yellow-brown, tightly adherent, hyperkeratotic rough lesion that has got a reddish base. And this one is another actinic keratosis. Here, this lesion is more elevated and showing a stuck-on appearance like that is seen in seborrheic keratosis. However, this lesion of actinic keratosis is not greasy, and it is hard in consistency and rough sandpaper surface, and it is painful when scraped. Speck or spreading pigmented actinic keratosis is another rare presentation of actinic keratosis. Uh, in this, the actinic keratosis look like lentigo maligna, but it is rough and therefore it feels like actinic keratosis. So the distinctive feature is include its size, that is more than 1.5 centimeter, and its pigmentation, that is brown to black and variegated in appearance, and there is history of slow spreading, especially the varicose surfaces. So in this picture there is another non-pigmented actinic keratosis in the preauricular area. The basal cell layers show cytologic atypia, and this atypia may accompany hyperplasia or atrophy that is associated with epidermal thinning. The atypical basal cells display pink or reddish cytoplasm due to this keratosis. Presence of intercellular bridges is a feature that differentiates this condition from basal cell carcinoma. The superficial dermis show elastosis that is marked by presence of thickened blue-gray elastic fibers, and the stratum corneum is show thickening, and cells of the stratum corneum retain their nuclei. This is termed as parakeratosis. The lesion may progress to involvement of full thickness of the epidermis by dysplastic cells as seen in this picture, and this is the development of in situ squamous cell carcinoma. This photomicrograph is showing the features of actinic keratosis. This red arrow is pointing towards the atypical crowded keratinocytes that are present in the lower portion of the epidermis, or Then this dark green dark green arrow is pointing towards the parakeratosis, that is the presence of nuclei within the stratum corneum. The blue arrow is pointing towards orthokeratosis, that is the presence of thickening of these stratum corneum, and these are non-nucleated cells. Hair follicle that is pointed by this yellow arrow is spared by these atypical epidermal keratinocytes, and in the superficial dermis this light green arrow is showing the elastosis. This elastosis can be more easily identified by reticulin stain. Another photomicrograph that is showing this features of the actinic keratosis. There is cytologic atypia within the stratum basale and the lower stratum spinosum, and there is loss of polarity also. Band-like lymphocytic infiltrate is often present, and parakeratosis is marked by this arrow is present only in a small focus, while this is a high power view, and this is showing the cytologic atypia of basal keratinocytes. Many histologic variants of the actinic keratosis have been identified. One is termed as acantholytic. There is lack of intercellular adhesion with clefts containing rounded acantholytic cells. Then there is atrophic, when the epidermis has only 3 or 4 layers of keratinocytes, or basalite, when most of the cells are basal like basal cell layer. Then bovonoid, when there is full thickness atypia, and this bovonoid is also carcinoma in situ. Then epidermolytic variant, there is vacuolar change of the keratinocyte at the upper spinous and granular layer with the presence of coarse keratohyaline granules. Hyperkeratotic variant is marked by development of cutaneous horn. Pagetoid has got the typical Paget cell-like cells, and the pigmented resembles solar lentigo that lacks atypia and has downward projection. So, course of this actinic keratosis, this may regress or remain stable. About 5% of the cases of the actinic keratosis, they regress, and but they have got a tendency to transform into malignancy, so should be treated by gentle curettage, freezing, or topical application of chemotherapeutic agents such as 5-fluorouracil. Imiquimod is a drug of choice for the treatment of actinic keratosis, and it activates toll-like receptors, and this due to activation of toll-like receptors, there is activation of cutaneous innate immune cells, and these cutaneous immune cells may recognize and eradicate precancerous lesions. Imiquimod is given twice weekly for about 6 weeks, and it causes cytokine dermatitis, and due to cytokine dermatitis there is local irritation and erosion, but this drug is highly effective and eradicates up to 50% of the lesion.